Have you ever stared at a patient's lab report and felt like you were standing at this massive fork in the road? You know that sinking feeling where one wrong turn could literally lead to disaster for your patient? When we're dealing with the kidneys, interpreting lab values isn't just about spotting what's out of range. It's really about understanding the physiological tipping points that drive them. Misinterpreting these signals, well, that can lead to catastrophic diagnostic errors. So in this explainer, we're going to audit those critical nephrology bifurcations. We're going to look at the exact moments where you absolutely must choose between two distinct pathways and figure out how to ensure you're following the true clinical signal instead of just getting lost in the lab's noise. Let's get into it.
Okay, let's dive into this roadmap. We've got 5 stops today. First, the acid-base master key. Second, RTA and the potassium pH bifurcation. Third, hyponatremia, the volume gatekeeper. Fourth, AKI, cellular versus interstitial. And finally, avoiding clinical pitfalls.
All right, Section 1, the acid-base master key.
Let's start with one of the most frustrating 50-50 dilemmas in all of internal medicine. You draw an arterial blood gas and a basic metabolic panel, and you spot a normal anion gap metabolic acidosis, what we affectionately call NAGMA. Right away, as the clinical investigator, you're faced with a binary question. Is this happening because of the gut or because of the kidney? See, a normal anion gap metabolic acidosis is fundamentally caused by a loss of bicarbonate. But where is it actually going? Are they losing it from the GI tract, like from severe diarrhea? Or is the kidney failing to reabsorb it or failing to secrete acid? Searching the GI tract when the kidney is actually the culprit is a massive waste of precious diagnostic time. We can't afford that.
So, this brings us to the ultimate diagnostic tipping point, and arguably the biggest executional gap out there, the urine anion gap. The formula is beautifully simple. You add the urine sodium and potassium, and then you just subtract the urine chloride. This single equation gives you a direct window into the kidney's functionality. See, normally, the kidney clears excess acid by excreting it as ammonium chloride. But since we don't routinely measure urine ammonium directly, that urine chloride acts as our surrogate marker. If the kidney is doing its job and pumping out lots of ammonium chloride, the urine chloride level will be super high, and that drives the overall equation right into negative territory. And this brilliantly illustrates the dividing line. If the urine anion gap is negative, it means the kidney is working perfectly. It's appropriately dumping acid to compensate for a problem happening somewhere else. We use the handy mnemonic negative to remember that a negative gap means the bicarb loss is from the gut, like with diarrhea. Conversely, if that gap is positive, the kidney is actively failing to excrete acid. That is pathognomonic for a kidney issue. So stop searching the GI tract because you've just diagnosed a renal tubular acidosis. Moving on to Section 2, RTA, the potassium pH bifurcation.
Once that positive urine anion gap confirms the kidney is the bad guy here, we hit our next major fork in the road. We have to unravel the 3 primary types of renal tubular acidosis. To pull this off, the clinical judge demands a strict audit of 2 very specific values, the urine pH and the serum potassium. Notice the distinct features defining these pathways. Type 1 RTA is a distal defect. The alpha intercalated cells simply fail to secrete hydrogen ions. And because they can't pump acid out, the urine pH stays stubbornly high, always above 5.5. Now, type 2 is a proximal defect. It wastes base early on, though eventually distal compensation drops the urine pH back below 5.5. What's crucial is that both type 1 and type 2 share a low serum potassium. And hey, here is a classic dangerous mistake to avoid. Giving a type 1 patient an ammonium chloride acid load to test their acidification without monitoring them. Doing that can trigger severe, life-threatening hypokalemia. Just treat type 1 with oral bicarbonate or citrate and skip the risky tests.
But then, we have the outlier, type 4 RTA. If you check that serum potassium, type 4 is the only RTA that presents with hyperkalemia, that is, high potassium. It's driven by an impaired mineralocorticoid effect. This could be from a lack of aldosterone entirely, or a resistance to it, which is often triggered by medications like ACE inhibitors. The urine pH here is typically less than 5.5. Spotting that high potassium is your immediate blaring signal that you're dealing with a type 4 RTA. And that requires a completely different management strategy, usually focused on loop diuretics or fludrocortisone.
Section 3, hyponatremia, the volume gatekeeper.
Now let's shift gears to one of the absolute most dangerous challenges on the wards, hypotonic hyponatremia. The consequences of getting this wrong? They aren't just abnormal lab values on a piece of paper. They are severe, devastating neurological outcomes. The diagnostic dividing line here almost always comes down to differentiating between true salt wasting, like cerebral salt wasting, and SIADH, the syndrome of inappropriate antidiuretic hormone. Here's where so many clinicians fall into a dangerous trap. They look at the initial labs, they see a high urine sodium, and they think, boom, I have my answer. But high urine sodium is just distracting noise. It's present in both conditions. The true signal here is the clinical volume status. Think about it. Cerebral salt wasting is a state of hypovolemia, a primary loss of sodium that leads to severe volume depletion. SIADH, on the other hand, is a state of euvolemia, where the body is just inappropriately holding on to free water.
You're also going to frequently see a urine osmolality threshold of greater than 100 milliosmoles per kilogram, but please don't let this confuse you. This shared threshold simply indicates that antidiuretic hormone, or ADH, is active in inserting aquaporins into the collecting duct. It absolutely does not tell you why it's active. It can be totally appropriately active in a dehydrated hypovolemic patient who is desperately trying to hold on to water, or it can be wildly inappropriately active in a euvolemic patient with SIADH.
So the crucial point is how this dictates our treatment and exactly why your physical exam is so incredibly vital. Treating a euvolemic SIADH patient requires fluid restriction or salt tablets to stop them from holding on to more free water. But imagine making a diagnostic error and applying fluid restriction to a patient who actually has cerebral salt wasting. Because they are already profoundly hypovolemic, restricting their fluids is going to worsen their circulatory collapse and could literally trigger an ischemic stroke. They need aggressive volume and salt replacement. You have to treat the volume status, not just the sodium level.
Let's move on to Section 4, AKI, the cellular versus interstitial axis.
When a patient's creatinine suddenly spikes, we have to immediately discern the structural pathways of the damage. Are we looking at a cellular destruction problem, or is this an interstitial inflammation problem? This pits acute tubular necrosis, or ATN, directly against acute interstitial nephritis, AIN. ATN is fundamentally about ischemic or toxic insults to the tubular cells themselves. Think prolonged hypotension or toxins like IV contrast and aminoglycosides. AIN, on the other hand, is a type 4 inflammatory allergic hypersensitivity reaction happening in the space between the tubules, the interstitium.
To definitively identify ATN, we have to look at the urinary sediment. Because those tubular cells are dying and sloughing off, they form very specific structural markers, muddy brown granular casts. And yes, they look exactly as gross as they sound. Furthermore, because these heavily damaged tubules can't reabsorb sodium anymore, the fractional excretion of sodium jumps above 2%, and the absolute urine sodium typically exceeds 40 milliequivalents per liter. The destruction is right there, clear as day under the microscope. Now, AIN presents entirely differently. This is typically a reaction occurring about 7 to 10 days after starting a new high-risk medication, like NSAIDs, penicillins, or sulfonamides. The drug timing vector is key. The sediment here will show white blood cell casts, or what we call sterile pyuria, meaning white blood cells in the urine but with a totally negative bacterial culture. Now, here's a massive, dumb mistake to avoid. Do not wait around for eosinophils in the urine to diagnose AIN. Assuming every single AIN patient is going to have that classic triad of fever, rash, and eosinophilia is a huge error. As the source material explicitly notes, that triad is actually present in less than 10% of cases. The real actionable signal is a sterile pyuria and a rising creatinine tied directly to a recent drug start.
And that brings us to Section 5, avoiding fatal clinical mistakes. Let's move to and see how this builds into the real-world stakes for our patients. Take a look at this quote regarding hyponatremia. It's a really stark reminder. It mentions neurologic sequela, which is really just a polite clinical way of saying cerebral edema, seizures, coma, or even brainstem herniation. If you restrict fluids in a hypovolemic patient, or if you blindly give an acid load to an RTA patient without rigorously checking their potassium, the labs might just seem like numbers on a screen, but the consequences for the person sitting in front of you are totally life-altering. Now, what's really interesting about this slide is how it perfectly synthesizes our golden rule for today. Treat the patient's signal, not just the lab's noise. A positive urine anion gap is a blazing signal cutting through the noise of a low bicarbonate. A low potassium is the true signal defining a type 1 or 2 RTA, just like a high potassium zeroes you in on a type 4. Euvolemia on your physical exam? That is the signal that overrides the confusing noise of a high urine sodium and SIADH. And of course, sterile pyuria is the signal for AIN, even when eosinophils are absolutely nowhere to be found.
So as we wrap up this explainer, I really want to leave you with this final thought to reflect on for your own daily practice. The next time you're staring down a deranged lab value, you have to ask yourself, are you relying on just a single number to make your diagnosis? Or are you stepping back, looking at the sediment, checking the physical volume status, calculating those gaps, and auditing the entire clinical picture? Because, at the end of the day, the difference between those two approaches is the difference between getting completely lost in the noise and safely guiding your patient right through that diagnostic fork in the road.